staff members or colleagues that were planning to attend but are unable to attend this webinar, it is being recorded. Can ask your clinical specialist or area manager, and we can get the link to you, and it should be posted on the intranet soon. As a reminder, this is the webinar for coding strategies. It's really a brief refresher on ICD coding as well as CPT coding. So we're going to start with ICD coding, and I'm trying to change my verbiage a little bit because we will be transitioning soon from ICD 9 to ICD 10. So we're going to first talk about ICD coding in a general sense because the same principles will apply to ICD 10 coding as do for the current ICD 9 coding. Our goal for this afternoon is to meet the 3 objectives that I have listed here. So at the conclusion of the presentation, you will be able to define what an ICD code is, as well as to be able to accurately select CPT codes and to match interventions provided, and then to have an improved understanding of how code selection and documentation are interrelated and go hand in hand. So first of all, what is an ICD code? Most of us are going to know that as an ICD 9 code because it is, we are currently using the 9th revision. ICD stands for International Classification of Diseases. And these codes give us a common language among care providers as well as insurance companies to talk about diagnoses and diseases. So every disease or disorder has a number that's associated with it. And each of these numbers can be between 3 and 5 digits long. The number of digits is going to tell us the specificity of the code. So the shorter digits, the 3-digit codes, are going to be more generic, more general in nature, and the 5-digit codes are going to be more specific in nature. So why do we use ICD-9 codes? Why are they important? And there's 2 big reasons. The first one is it supports our intervention. ICD codes support our intervention by explaining to payer sources, reimbursement sources, what we're doing, why this person needs therapy in a 3 to 5 digit code. And so we want to be sure that we're being as accurate as possible when we're picking those codes and that it truly matches the intervention that we are providing. In addition, our codes support our documentation and vice versa. Our documentation should support our codes. So information in the documentation should really lead you to choosing ICD codes versus choosing ICD codes and then not having that information connect to the documentation. Sometimes it's the ICD codes that are the only source to our payer, the only source of information to our payer about what it is that we're doing with a patient. And sometimes there are decisions about claims, whether they're going to be paid or not, purely based on the ICD codes. So it's extremely important for all evaluating therapists to understand this process as well as rehab directors in order to guide each other to make sure that we're choosing the best codes that support the services that we're providing. So the first question is, who decides what ICD codes I can use as a therapist? Oftentimes I will get the answer that it's SMART. If the code is in SMART, I can use it. That is actually incorrect. The correct answer is your MAC, or Medicare Administrative Contractor. Medicare, CMS, is a huge conglomeration. So they use a network of contractors called MACs, or the Medicare Administrative Contractors, to process Medicare claims as well as enroll healthcare providers in the Medicare program. So it's these MACs that actually handle the individual claims that we send forth to Medicare on a regular basis. And each MAC covers a different geographic region. So depending on where you're located within the United States, you are reporting to a different MAC. For those of you that are located in Indiana, Iowa, or Missouri, your MAC is currently Wisconsin Physicians Services. If you practice in Illinois, your MAC is National Government Service, or NGS. If you're in North Carolina, South Carolina, or Virginia, your MAC is Palmetto GBA. If you're currently in Ohio, your MAC is CGS Administrators. And in Colorado and Texas, your MAC is Novitas Solutions. So you can see across the states where Legacy provides services, there are several different MACs. Each MAC has their own set of rules and regulations. So you have to be familiar with what your MAC dictates as far as what ICD-9 codes can be used on claims, and we'll talk about that a little bit more. Let's first, though, talk about how we're going to choose an ICD code. So the first thing that you want to think about in your selection of an ICD code is to think about what is the primary reason that the person you are treating is seeking treatment from you, whether that's OT, PT, or speech. What is the overall overriding reason that this person is seeking your services at this time? The best way to get that is your reason for referral. I do documentation review, and I start with that reason for referral box. That reason for referral box really should paint a picture of who this person is and why they're needing our services. That then leads me to selection of ICD codes. So after I read that reason for referral box, I have a general idea in my head about what the code should be, and then I go back and check to make sure that those things match up. In addition to choosing the most relevant diagnosis, you also want to choose codes that are the most specific to the diagnosis that we are treating or to the impairment that we're treating. The other thing is that you may come across situations where you have information about a patient as far as codes, and that code is not in your MAC or LCD. And so you want to choose a code that is part of your LCD that the MAC puts out. The LCD stands for Local Coverage Determination. So if you choose a code and you put it on the claim that's not part of your LCD, it will result in an automatic denial, an automatic return, and we will not get paid for that claim because of the rules that the MAC has set forth. So going back to who chooses what codes you can use, it is your MAC and not SMART. Just because the code is in SMART does not mean that it is approved on your LCD. As you can tell from earlier when I listed all the different MACs, SMART, we have to put all those codes in to cover all of the areas that Legacy covers throughout the United States. So please rely on your LCD dependent on the state where you're at versus choosing a code that's in SMART. So what designates a ICD code as medical or treatment? This is a conversation that I have all of the time with the folks in my area. In reality, there's no such thing as a medical diagnosis and a treatment diagnosis. It's put on paperwork to help clinicians choose codes. But in reality, when that bill or that claim goes to Medicare, there is a primary diagnosis and then there are subsequent diagnoses. It's just one big list. If you are a rehab agency and the billing is done by legacy, you have a total of 8 codes that you can put on a claim. If that person is on multiple disciplines, it's 8 for the entire claim. So if the person is receiving 3 types of therapy, and PT, OT, and speech all have 3 claims on the code, or all have 3 codes on the claim, not all of those will get sent to Medicare because we're limited by our software. So it's really important that you choose codes that are very specific and truly represent the main reason that the patient is seeking your service. So the primary code or the primary medical diagnosis should be the overriding reason why this person is seeking services. Subsequent codes are going to describe coexisting conditions that may affect patient care. So for example, if somebody is admitted and somebody has had a fall and now they have hip pain and they're limping because of that fall and hip pain, the overriding reason or the primary reason that they're seeking services is because they had a fall. Subsequent conditions would be pain as well as a gait abnormality. They also could have weakness. Depending on the reason for the fall, there could be a balance impairment. So those are all things that you could choose to code the particular claim that you're working on. This is another common question that I get. Does the code I choose have to be on my patient's diagnosis list? The answer to that is no. And often, the code that you want to use is not going to be in the medical history of the patient. That is because we, as OT, PT, and speech, have our own list of codes. Doctors have their codes. Radiologists have their codes. It all describes the services that we're providing. So it would be very uncommon for the doctor and the therapist to use the same code. Once you put that code on your plan of care and the doctor signs it, it becomes part of their medical history. There are some physicians that you could send a fax to that says, consider adding this particular ICD code to the patient's diagnosis list. But in general, the majority of the time, if you put it on your plan of care, the doctor signs it, it becomes part of that person's medical history. In some cases, excuse me, let me go back just a minute. The reason that we want to do that is because, again, our codes are limited to what we can use by the MAC and the LCD that the MAC puts out. An exception to that case would be a community that services Part A, and they are under the impression that the therapy diagnosis must match the admitting diagnosis. That is actually not true because most of the time that admitting diagnosis is going to be a nursing need and justify the need for nursing rather than therapy. So if you are in a community that provides Part A services and the billing department requests that our codes match, we certainly want to do what's best for the relationship of the building, but also know that could be an opportunity for education. All right, coding to the highest specificity. So we want to select codes that are as specific as possible. Like I mentioned earlier, codes are between 3 and 5 digits. The more digits a code has, the greater the specificity. So as an example, 719, the definition of that is other and unspecified disorders of the joint. So we really don't know what's going on in the joint. We just know that it's a joint. We don't know where in the body. So it's very vague in its description. 719.4, so we're adding that fourth digit, now tells us that it's not just a joint, but there's pain. That's the problem in the joint, is there's pain. We still don't know where that pain is located, but by adding the fifth digit, that tells us that the pain is in the joint and it's in the shoulder. So it's much more specific by adding those 2 digits after the decimal point than what we have when we just have the 719. Just as a side note, if you have a code that is 719.0, that 0 will get dropped off and it becomes a 3-digit code. But if it were to be 719.01, then that is a 5-digit code. So just something to remember. So the other piece of this is that we want our documentation to support the codes that we choose to describe the situation that is before us and to describe our interventions. So our documentation should describe what is going on with the patient, what is their condition, what is their medical history. We want to use words that describe not only specific diagnoses, but also what we're seeing. What symptoms are they presenting with? How is it affecting them on a functional basis? So not just pain, but how is that pain affecting their ability to participate? You want to be as specific as you can as far as the area of the body, and then any kind of comorbidities or complexities that could impact the treatment and the care of this resident. So here's a couple of examples. Like I said before, when I do documentation review, I look at that reason for referral to help guide the codes that are chosen. So our first example, the reason for referral, states that the patient is unable to care for self at home. They've had a functional decline in dynamic balance, and they also have a history of bilateral knee flexion contractures. So my first reaction to this is I have a little bit of a sense of what's going on, but not really a clear picture is being painted of why this person needs services. Based on the information that we do have, the codes that were selected for this particular claim, the medical diagnosis was 401.9, hypertension, and then the treatment diagnosis was 728.2, muscle use, disuse atrophy, excuse me. So if you're looking at this, first of all, hypertension is not going to be a main reason for therapy intervention. We don't treat hypertension. As a side note, we also don't treat dementia. So we should not see dementia as a primary diagnosis. We treat the symptoms of dementia. We don't treat the disease itself. So same thing with hypertension. We may do interventions that help to control how the hypertension is managed, but we do not treat hypertension specifically. So for this particular reason, or for this particular patient, the knee contractures are relevant, but that's nowhere in the codes. It doesn't appear on the code list at all. And it should probably be the primary diagnosis based on the reason for referral. The other thing that I would consider is that there seems to be a balance deficit. So the definition, or one of the codes that you could use for balance would be lack of coordination. That would cover balance interventions. Then the bilateral upper extremity strength is 4- out of 5. That's not a huge strength deficit, but there could be some weakness there. So and then there could be some muscle atrophy because of the bilateral knee flexion contractures. It's just really hard to say because there's not a ton of clarifying information in that reason for referral. Moving on to the next example, nursing notified therapy of need for range of motion, orthotic splinting due to patient with developing contractures and increased tone in bilateral wrist, hand, and fingers. In this case, the medical diagnosis was 348.9, brain condition, not otherwise specified is what NOS stands for. Treatment diagnosis was listed as joint contracture for the hand, joint pain in multiple joints, joint stiffness in multiple joints, muscle disuse atrophy, and then lack of coordination. So pretty good codes as far as specificity, except that the medical diagnosis, really that's a piece of information that is probably contributing or may be contributing to what we're seeing with the patient, but that really should land in the medical history rather than in the medical diagnosis. It's really the 718.44 joint contracture that's the main reason for the referral. It's the main source of the intervention. So the contracture could be leading to pain, or it could be stiffness that's leading to pain. And so that's how you want to think about choosing those codes, is this kind of umbrella and what has led to what other problems. The third example, unable to perform mobility due to spastic right hemiplegia. Patient presents with spastic right hemiplegia and influence ability to sit from supine as per prior level of function. So we can have a decent picture of what this person looks like on evaluation. Medical diagnosis is muscle disuse atrophy, and then treatment diagnosis, abnormality of gait. The thing that stands out to me is that there is no code to describe the hemiplegia or the hemiparesis. So 342.11 would describe hemiplegia and hemiparesis affecting that dominant side. And then finally we have the last example. 88-year-old lady has shown some declines in ADLs, including having additional problems requiring additional staff support during transfers. She was sick 2 weeks ago with GI problems and virtually bedridden for several days, along with having no appetite. She has shown declines in strength, endurance, balance during standing, and fearful of falling during pivot transfers. Would benefit from skilled intervention to address above issues and assist patient to returning to her prior level of function. So you really have a good idea of what's going on with the information. The information describes that the patient was bedridden, so this can lead to muscle disuse, atrophy. Osteoarthritis may be an existing condition that wasn't necessarily mentioned in the reason for referral, but is in the medical history. That's going to complicate treatment. Debility is a pretty vague diagnosis, but it would be okay because we have stronger diagnoses on the list. It's not something that really accurately describes the intervention that we're providing. We're absolutely going to treat muscle weakness as well as lack of coordination. So at this point, are there any questions with the selection of ICD codes? No questions? Okay. Well, we will move along then. Oh, looks like I might have a question. NEC, what the question is, what does NEC stand for? NEC stands for not elsewhere classified. Good question. And then the second question is, how do we get the LCD list? It is the instructions for obtaining your LCD depend on which MAC you're in. So I have instructions for Palmetto, and I am going to direct you to your clinical specialist in your region. I will tell you that I think it's Indiana, yes, Wisconsin Physician Services does not have a specific list of ICD codes, and so I do have a generic list, but the coverage requirements are going to be by the national Medicare standard. So I will send out the generic list that I have, and it's pulled from Palmetto. So it's going to give you a pretty good tool to use because, like I said, some MACs do not provide a list of specific ICD codes. The other question is, you've indicated muscle disuse atrophy. Would you recommend weakness as well? Absolutely. And to be honest, the muscle weakness code is going to be a better used code. The document that I pulled from is an older version of training, and I'm not sure that muscle disuse atrophy is an approved ICD code on a lot of MACs, but definitely 728.87 is pretty well accepted throughout the country. Okay, any other questions? All right, we will move along then to CPT codes. Okay, so what is a CPT code? CPT stands for Current Procedural Terminology, and it is a coding system that was developed by the AMA to assign, again, a numeric code to tasks that we use during intervention. So the ICD codes describe the overall plan of care, the deficits that the person has, and then the CPT codes will describe the interventions that we provide to support or to enhance or to improve the deficits that we've identified by the ICD codes. So what I'm going to do is go through the majority of the codes that we use in practice. This is where your additional handouts may be helpful. I've provided two different handouts, and they essentially cover the same thing. They're just in different formats for different learning styles. Both of those forms are also on the intranet, or you can contact your ARCs for a copy of that. So the first code that we'll talk about, we're just going to go in numerical order, is 92610, Evaluation of Oral and Pharyngeal Swallowing Function. So this is what a speech pathologist, or in some cases an OT, would use to describe an evaluation or to bill for a swallowing evaluation. As far as documentation for this type of eval, we want to include things that are outlined for us in SMART. But the other thing that we want to do is tie in the deficits that we're seeing, any comorbidities, and what we can do to help this person now. Why do they need our services now? 92526 then is the CPT code for swallowing dysfunction. And so this is the treatment code for somebody that you've evaluated for a swallowing disorder. Documentation for swallowing treatment, when you have a chronic progressive disorder, the intervention is going to be short-lived. So you're going to focus on positioning, diet, feeding modifications. Your documentation needs to support establishing and training somebody to carry out a functional maintenance program for the interventions that you provided. For a chronic disease, documentation should support the loss of function and the potential for change. So the gist is, tell me what you did with the patient, tell me why you did it, and how the patient responded. As I do documentation review, I find that folks are great at telling me what you did, but not necessarily why you did it. And that's a critical piece to documentation to support why the skills of a therapist are required. Examples of documentation to support the use of 92526 would be things like training the caregiver in techniques, working on proper head and body positioning during food intake, looking at the amount of intake per swallow, making sure that the person is on the appropriate diet, looking at ways that we can facilitate a swallow response from that person, food consistencies, laryngeal elevation techniques, as well as some neuromuscular facilitation exercises, compensatory swallowing strategies, and then any kind of oral sensitivity training. So all of those things would fall under the swallowing treatment for speech. And just as a reminder, this code is an untimed code, meaning we are reimbursed at $1 amount regardless of the amount of time that we spend with the resident. On this slide, you will see that we have our updated speech evaluation codes. It used to be that speech pathologists had two to three codes to choose from for their interventions. You have a swallowing code and then a speech evaluation code. What ASHA has done is they have taken that code for speech eval and really separated it out to clarify what exactly you're evaluating. So 92521 is looking at speech fluency. So stuttering, cluttering, if you're assessing that, then you would bill 92521. 92522 is really focused on sound production, the person's ability to articulate. If they have an apraxia or dysarthria, then you would use 92522. 92523 is bolded because based on our analysis as a clinical team, we feel like this is probably the code that's going to get used most often in our clinical settings. I'm not saying that the other ones will not be used, but this seems to fit the majority of interventions. So this is evaluation of speech sound production as well as an evaluation of comprehension and expression. So if the person only has deficits in sound production, you would bill 92522. But if they've got deficits in sound production as well as language, comprehension, and expression, it's going to fall under that 92523. 92524 is behavioral and qualitative analysis of voice and resonance. And then the supporting documentation is just like any other evaluation. What were your objective measures that you use? What were subjective evaluations of the patient's performance? Justifying why you need to continue treatment with this person. What are the deficits that you noted? How do they compare to normative data? 92507 is then the treatment code, and that has not changed. So that will be the treatment code regardless of the speech evaluation code that you use. So 92507 is for the prevention, restoration, amelioration, or compensation for disorders of speech, articulation, fluency in voice, language skills, cognition, pragmatics. I do want to point out that it does talk about cognition here. So oftentimes, 99.9% of the time, as a speech pathologist, if you're addressing cognition for somebody who has, somebody in our setting, it's going to fall under this speech treatment code. The only time that you would bill cognitive retraining is if there is not a diagnosis of a progressive neurological disorder. If you don't have a diagnosis of dementia, but you're pretty sure there's some cognitive loss, the person should be at least an Allen level 5 in order to bill that cognitive retraining code. That is true also for occupational therapy. So going back to the 92507, supporting documentation would include any caregiver education that you provided and return demonstration of that education, not just that the person return demonstrated, but how accurate were they, how competent were they with that return demonstration. Tell me the specific intervention that you provided. How much assistance did the patient require? How did the patient respond? Why did you do the intervention that you did? 96105 is assessment of aphasia. This should be used anytime you're assessing somebody who has aphasia. So documentation is going to include objective measurements of performance, as well as the specific intervention provided. 96125, standardized cognitive assessment. This is a code that can and should be used by both speech and OT. It is a code to describe when you are administering cognitive assessments, and it has to be a standardized tool, hence the name, standardized cognitive assessment, in order to use this code. So some examples, these are just a few of the examples, would be the RIPA, the LOTCA, the MVPT, and of course the Allen. So anytime that you administer the leather lacing and you want to bill it under 96125 as an OT, as an evaluating OT, and as a speech therapist, an assistant would not be able to use this code, nor is it accepted by PT. The unique thing about this code is that it is per hour of the therapist time, and that includes not just the face-to-face time administering the test, but the amount of time that it took to interpret and then prepare the documentation that you're reporting the results of this tool. So 96125 should be used by evaluating OTs as well as speech pathologists when you're administering the leather lacing. Because it is an hour of time, in order to bill correctly, it should be a minimum of 31 minutes that you spend with the patient. So most of the time when you administer the placemat, it's not going to be long enough to bill this 96125. There may be an occasion where it is, but on the other hand, it usually on average takes anywhere right around that 45-minute mark to administer the leather lacing and then to score it. And you want to then input the exact time that you spent with the person. If it wasn't 60 minutes, don't put in 60 minutes. If it was 58, you're going to put in 58. All right, moving on, we've got 97001 and 97003. These are our PT and OT evaluation CPT codes. Again, we want to document the necessity of therapy through as many objective tools that we can. Looking at that plan of care, the reason for referral should dictate the ICD codes. The ICD codes should coincide with the goals. The goals should coincide with the deficits. And so all of it should go together to paint a picture of what this person looks like and what are we going to do to affect the deficits that they're presenting with. 97032 is electrical stimulation. We have two codes that are available to us for eSTEM. This 97032, is going to be used less often, less frequently than the next G code for electrical stimulation. So for this one, if you are providing eSTEM to direct motor points, if you're doing instruction in the TENS unit, or if you're using the e-stim to facilitate movement that you couldn't otherwise get during an activity, 97032 would be the code that you use. And then the documentation is going to be the type of e-stim, such as NMES, what type of e-stim are you providing, where is it being provided, any kind of objective rating that you can get, whether you use strength or the functional deficit, pain location, and the effect of pain on that person's function. The G0283 code is the code that we're going to use the majority of the time because it better describes the intervention that we're providing. Unless you're doing wound care. If you're doing e-stim for wound care, then it's G0281. But most of the time, we're going to use this G0283, and you want to provide the same documentation that you would for 97032, the area that you're applying it to, why you're applying it. If it's for pain, you know, we need a pain scale. We need information to support whether or not this modality is working. We really want to show objective information within 6 visits if we're using the tool for pain or swelling. Documentation has to be extremely thorough and extremely detailed for max to pay for e-stim more than 12 visits if we're not getting significant gains from the use of that modality. The modality really is supposed to be used as a preparatory technique. So modalities should never be used in isolation. There should always be a functional treatment during it or afterward. And as far as billing time, you cannot bill for the run time of e-stim. You can bill for the skilled time it takes to set up the device, to adjust it, and then to take down and do a skin check afterwards. But you cannot bill for the amount of time that it's actually running. 97035 is ultrasound. For documentation to support the use of ultrasound, you want to address the area that's being treated as well as document the frequency and intensity of ultrasound. Any kind of objective information that you can use to support the intervention is going to enhance your documentation. So range of motion, functional limitation, pain is going to be in the subjective findings. How did they participate in therapy after you used ultrasound versus if you did not use ultrasound. 97110 is therapeutic exercise. So the definition of therapeutic exercise is to develop strength and endurance, range of motion, and flexibility. I feel like when I do documentation review for this code in particular, it's really a code that sometimes becomes a catch-all, and really the interventions don't necessarily fit. So we want to try to use as objective information as possible to support the use of this code. A lot of the interventions that we provide that fall under therapeutic exercise could be seen as non-skilled intervention if we don't have good documentation to support it. So really describing why you're doing something for therapeutic exercise is a must, as well as using evidence-based clinical programming to support your intervention. So the 1-Rep Max is a tool that we have to be using to support our interventions with therapeutic exercise. Other supporting documentation is going to be any kind of exercises that were added or changed, adjustments to a home exercise program. You really have to support the need for more than 12 to 18 visits for therapeutic exercise. And the 1-Rep Max program will help you do that. The other thing that you want to include is what is the specific exercise that was performed. Upper extremity exercises in all planes is not specific enough. unless you literally did every single possible range of motion in every single muscle of the upper extremity, which is often not the case. So please be very specific in the exercises that were performed, why those exercises, what is that exercise going to lead to, any kind of instructions that you gave or assistance that the person needed. If you were doing any kind of taping, either McConnell taping or kinesio taping, that is also going to fall under 97110. 97112 is neuromuscular re-ed. This is used when we're working to really restore balance, coordination, kinesthetic sense, posture, and proprioception. So if you are working with your patient because they've had a fall and you're trying to restore their balance, you've assessed them with the Berg balance, that can fall under 97112. If you're using the B-HIP program, those treatments are going to fall under 97112. The biggest thing about picking the right code is the why, because you can do the same intervention 3 different times and have 3 different codes based on why you did the activity that you did. So that is an essential piece in ensuring that we're choosing the right CPT code to describe what we're doing. The other thing that's going to be helpful to include in supporting 97112 is caregiver training, any kind of carryover, the frequency of falls that the person is having. Whoops. And then any kind of loss that of function that the patient has had because of those deficits. If it's a loss in the ability to perform either ADLs or IADLs, if their functional mobility has been impaired, any kind of coordination. And then again, being very specific on the exercises. Remember, you've got some great skilled language for you to use as part of that B-HIP program. It gives you the purpose laid out in black and white as part of that, that manual. So you can list the exercise and then use those words verbatim to support the activities that you're doing. 97116 is gait training. Gait training is often a tricky code. It includes stair climbing as well as training patients and caregivers in ambulating patients. The purpose of gait training is not to increase the distance that a person can walk. So really we want to focus on the components of gait. So you want to look at things such as the use of an assistive device, how they're able to negotiate that assistance, how they are with heel strike, cadence, toe off, all of those components that really go in to making an efficient gait pattern. That's what should be addressed and documented if you're billing gait training. So if you're working on activity tolerance in order for the patient to be able to get from their room to the dining room, that's not gait training. Gait training, again, are those component factors, but it also can include stair climbing as well as training in a new assistive device. 97530 is therapeutic activities. Therapeutic activity, the definition, it would be dynamic activities to improve functional performance. So it's any activity that you're doing to improve the person's ability to bend, lift, carry, reach, perform ADLs, anything that you're doing to improve their functional capacity. It is also going to be used when either a PT, PTA, or OTA is administering the leather lacing or placemat. You're going to bill that under 97530. Documentation to support the use of 97530 is going to include the need for services beyond 10 to 12 visits. Why does this person continue to need services? And you can include information that's objective in nature, such as ADL loss, balance, strength, coordination, range of motion. What are the specific activities that you did with the patient? Tell me why. Why did you have the person stand instead of sit? Why did you have the person reach to the right instead of the left? How much assistance did they need? How did they respond to the intervention? How many rest breaks did they need? How many cues did they need? Were they able to perform, you know, for 10 consecutive minutes, or did they need rest breaks? 97535 is self-care home management training. This is where OTs thrive, and any treatment related to ADL performance, compensatory strategies, meal prep, IADL tasks can also fall into this. And as an OT, you should be assessing ADLs on every single patient that comes through your door. Whether or not that was the reason for referral or not, we just learned so much valuable information through observation of an ADL. And it's not just limited to showering and dressing and toilet transfers. It's really so much more than that. There is a tool on the intranet as part of the ADL manual that kind of guides you and does an activity analysis of all of the ADLs that are described in the OT practice framework. That is a great tool to, not only to make sure that you're addressing all of those things, but then to help provide the supporting documentation. So what kind of equipment does this person need? Document that. How much assistance did they need? Why did they need that assistance? Was it a cognitive reason or a physical reason? What kind of instructions are you giving? Describe any caregiver education, and then the response to that education. 97537 is available for some folks. Not all areas will reimburse 97537, but it is community work reintegration. And these are things like shopping, transportation, money management. So the more higher level IADL skills can be billed under 97537 if it's available for your MAC. Supporting documentation, objective measurements of community IADL impairment, specific training, assistance, patient's response. And really this is going to be a few visits, 4 to 6 visits at most, and you really have to tie in the medical necessity. It can get a little tricky with documentation to really make sure that we are supporting the medical necessity for the community reintegration piece. So in review, for any documentation that you're doing for CPT codes, you want to include as much objective information as you can, as much subjective information as you can to support the objective information. Give the specific intervention that you provided, how much assistance was required, how did that patient respond, why did you do that intervention, and then any kind of modifications that you're going to make for subsequent visits based on the visit today. So tell me what you did, tell me why you did it, tell me how the patient responded to it. Okay? All right. What questions are there now? I see I have a couple that have popped up. One is, should muscle weakness be medical diagnosis and or treatment diagnosis? Really, there's not a black and white answer to that. The answer is it could be either. There's oftentimes no reason to duplicate a medical diagnosis and treatment diagnosis code. If you have 2 different codes, one's going to be in the medical, one's going to be in the treatment. If you absolutely only have one code out of all of the codes that are available to you, that's when it would be repeated. But there could be an occasion where muscle weakness is going to be the primary medical diagnosis, and there are going to be other occasions where it's going to fall under the treatment diagnosis. So, for example, if the person has incontinence, the primary medical diagnosis is going to be incontinence, and the treatment diagnosis is going to be muscle weakness. If the main reason that the person is coming on to therapy is to establish a home exercise program because they are weak, then muscle weakness may be the medical diagnosis. And then the next question, other than memorization, is there an organizational pattern to ICD codes for quick reference to speed documentation to most detailed? Great question. I really don't have a great answer for that. I don't know of a quick reference. Many of my staff members say that it's too time-consuming to come up with detailed codes. My response to that is it is also very time-consuming to write denial letters and to fight denials. So we want, there comes a point when you have established a lot of what your codes, you're going to use a lot of the same codes over and over. But there are occasions where you might come across a patient that doesn't fit what you're used to. So there is a link on the intranet. On the upper right-hand side, it says ICD-9 codes. If you click on that link, you can type in the search box, and it will generate some codes for you. Now, the caveat to that is the list of all of the ICD-9 codes that were ever available. So just because it's on that list doesn't mean it's your MAC. So you would have to go back and make sure that it's on the LCD that is provided by your MAC. What other questions can I answer? Okay, I'm showing on my screen that Beth White has a question, but I don't see your question written anywhere, Beth. And the same thing for Christy Pate. So I don't know if you guys are on the phone. Okay, I just double-checked to make sure everybody was unmuted. So if either of you have questions, you can email them to me because I'm sorry I can't see them pop up here. Let's see. So typically medical diagnosis and treatment diagnosis should not duplicate. Correct. There's no need because when that claim goes to Medicare, it's just submitted on a list or typed into a document on the computer. So there's no need to duplicate the codes. And then how often do updates for ICD codes, how often do updates for ICD codes happen? Well, ICD-9 has been around since 1970, so the big conglomeration doesn't happen very often. Specific LCDs from different MACs, it varies. There's not necessarily a rhyme or reason for when those codes are updated. Okay, here is a question, 781.99 versus 781.3 for balance. 781.99 is other neurological disorders not elsewhere classified, I believe. I'm going off straight memory there. That one typically is going to be a good overall medical diagnosis because it includes so many other things. 781.3, lack of coordination, really describes a balance deficit. So you could use 781.99 as a medical diagnosis and then 781.3 as a treatment diagnosis. Is there a site to check for most updated ICD? Yes, that would be your MAC. So in this case, it would be the Palmetto website. They're always going to have the most updated ICD-9 codes that are available. If you are in an area that does not have an LCD, again, I can send codes, and but I would encourage you to talk with your clinical specialist in your area about how to best choose those ICD-9 codes. Any other questions? All right, well, I thank you all for your attendance, and if you have questions that come up, you are welcome to email me or any of the clinical specialists. My email address is sking@legacyhealthcare.net, and any one of us would be happy to walk you through and go through some more specific coding strategies with you. So thank you for your time, and have a great afternoon.